So welcome, thank you for coming back. Last time we talked about the anatomy of the heart in pretty great detail. So tonight we're going to continue our discussion of anatomy of the cardiovascular system really by moving into the vessels and finding out sort of what the general structure of the vessels are and where the vessels are and where we can find them, and then talk about the sort of the circulation loops in our body. So we have some objectives again to work through. We're going to start by just a little bit of review, but then we want to talk about the general features of the vessel walls, the things that they have in common. We'll talk about the coronary arterial circulation and the venous return from the heart. We will talk about the major components of the pulmonary circulation and the systemic circulation so that you should be able to kind of describe those in general terms. We'll talk about the structural changes that occur at birth that represent a change from fetal circulation to postnatal circulation, or to post-fetal circulation. Then we're going to talk about where the major arteries are in the neck and extremities and where you can palpate pulses and sort of why you palpate a pulse, what information that can give you. We'll talk a little bit about the role of the autonomic nervous system in regulation of heart rate, sort of the innervation of the heart. And then we'll hopefully have time to talk about one of my favorite subjects, which is the lymphatic system. Woohoo! I'm sure you're all excited about that. So I hope we can have time to do a little bit of that. All right, so off we go. So you'll remember then that the circulatory system is composed of the heart and the blood vessels, and that the blood vessels really are the arteries and the veins and the capillaries, and we'll talk a little bit more about those in detail. And that the heart and the blood vessels work together to distribute the blood to our body, to bring oxygen and nutrients to the cells that need them, and then to return carbon dioxide and waste products kind of out of our system. The circulation of blood really supplies all the cells of our body with really vital elements to keep our cells active and healthy and to keep us alive. And they also help bring materials to our tissues to help fight infection. So the health of our circulatory system, of our cardiovascular system, is really vital. And the blood circulates in our bodies in essentially two loops. We're going to talk about three of them, but the two main ones are the systemic circulation and the pulmonary circulation. So we'll start out just very briefly talking about the general overview of these systems. We know that the left side of the heart, we talked about the heart last time, right side, left side, and the left side of the heart is really pumping that oxygen-rich blood out of the heart into the systemic circulation. And all of the arteries, so we have these main arteries that come, or a main artery that comes off of the heart, the aorta, that's carrying the oxygen-rich blood from the ventricle out to the systemic circulation. And the arteries that are in the systemic circulation are all carrying oxygen-rich blood. And that's in contrast to the arteries that are going to the pulmonary circulation. You might remember that the pulmonary artery, or the pulmonary trunk, comes off the heart from the right ventricle and carries oxygen-poor blood through the pulmonary arteries to the pulmonary circulation. So there's a little difference there. But arteries in general are the vessels that leave the heart. That's a consistent rule we can always remember. And then veins are vessels that are always bringing stuff back to the heart. Okay? All right. So let's move on and talk about some of the specifics of the heart, just sort of general overview of the heart, and then into the specifics of each of the circulatory systems that we just talked about. So remember that the heart is this pair of muscular pumps, a right side and a left side. The right side is responsible for pumping out to the pulmonary circulation, and the left side is responsible for pumping out to the systemic circulation. So that's all review. It's the heart's job, really, to maintain this circulation by pumping, right? So we get this muscular contraction because the heart is muscle. Myocardium is contractile cardiac muscle. So we have these four chambers that make up the heart. We have two atria separated by an interatrial septum, and then we have two ventricles separated by an interventricular septum. And these atria contract first, and their contraction essentially pushes the rest of the blood that's in the atria into the ventricles. Then that's followed by a ventricular contraction. So the ventricles will contract more or less simultaneously and pump the blood that's in the ventricles out to either pulmonary or systemic circulation. Okay, so that's your overview and review of the heart anatomy. And then you'll remember too that there are valves that control the backflow of the blood. So there's a valve between the right atrium and the right ventricle. That's the tricuspid valve. And there's a valve between the right ventricle and the pulmonary artery. That's the pulmonic valve. Right? So those are preventing blood from going back from whence they came. Right? You don't want the blood to backflow into its source. Then we have a valve between the left atrium and the left ventricle, bicuspid valve or mitral valve, right? And then we have a valve between the left ventricle and the aorta, the aortic valve. So each of those is helping to regulate the flow of blood in the right direction out of the heart or through the heart. Now, we know that the cardiovascular system circulates blood through the body, and it does this in a network of vessels that, again, are going to deliver oxygen and nutrients to our cells and tissues. This vasculature is a network of vessels that includes the great vessels off of the heart, which you'll see here, and the branches either to those or from those. And it also includes the arteries and veins that branch off of those to the rest of the body and then into the pulmonary circulation as well. So there are 5 different types of vessels. We have arteries and arterioles, which are smaller. We have capillaries, venules, and veins. Arteries are the large vessels, as I said, that carry blood away from the heart. Arterioles are just smaller types of arteries. And then we're going to work our way down to the capillaries. So as the arteries branch, they increase in number. But as they increase in number, they get smaller in diameter. And then as these arteries get smaller, they become arterioles, and they become more muscular. So I'll show you a cross-section of that in just a bit. So blood from the arterioles enters into this capillary bed that's within the tissues, and that's where the exchange of nutrients and gases takes place in the systemic circulation. So here's a picture that I'm not sure you have in your handout, but here's artery carrying oxygen-rich blood, and this is out in our systemic circulation in this example. So this is carrying oxygenated blood toward the tissues and going into smaller branches and then ending up in arterioles and then out into a capillary bed. These capillaries are very, very thin-walled. Their inner lining is really only one cell thick, one endothelial cell thick. So these are right next to the tissues, kind of in the tissues that they're going to supply, and they're one cell thick. So they really present a minimal barrier to exchange of materials across the capillary wall into the tissues. So you might hear these called exchange vessels. Capillaries are sometimes called exchange vessels. So these capillaries are organized in this capillary bed, and they're actually interconnected among the cells and tissues, and they actually close the loop between the arteries and the veins. So the arterial blood and the venous blood is actually communicating here. So at this arterial end, in this example, in the systemic circulation, oxygen and nutrients are going to kind of diffuse out of the capillaries into this tissue space, which is bathed in fluid. It's called interstitial fluid, or fluid within the tissues, kind of outside the cells, surrounding the cells and bathing them. So those nutrients and oxygen are going to flow out or kind of diffuse out of the capillary across the wall into this tissue space and then to the cells, where the cells will pick it up. And then the cells are going to get rid of their CO2, their carbon dioxide, and other waste products of metabolism. That'll move out into the tissue space and then find the capillaries, and the capillaries will pick that up more toward this venous end. And then the blood will then flow, carrying carbon dioxide and other waste materials, flow toward the venous system here. As these capillaries come together, as multiple capillaries merge, they become venules. And then the venules get bigger and join, and then they develop a muscular wall, and then they become muscular venules and then veins. And then the veins will then carry that material back to the right side of the heart. Okay, everybody with me so far? Okay. So blood from the capillaries then is carried by these post-capillary venules out here toward larger veins back to the right side of the heart. And the structure of these vessels, they have some similarities, but then they have some significant differences. So each of the vessels, with the exclusion of the capillary, has 3 walls, or 3 coats, or 3 tunics. So we call them tunica: tunica intima, tunica media, tunica adventitia. So the tunica intima is the innermost lining, innermost layer or coat. That's here. This center channel is called a lumen. So the opening, the middle tube, is the lumen. So this inner wall, this tunica intima, is the one that's intimately sort of bound or binds the lumen. Okay? So it's the internal layer. And remember, capillaries are really not in this category. We're talking about arteries and veins and arterioles in this discussion. So the lining of this tunica intima is really endothelium, maybe a bit of connective tissue, but largely endothelial cells. All right, so that's the tunica intima. The next layer is the tunica media. So that's this middle, thicker layer here. Okay. And that layer is really largely smooth muscle. It also has elastin and collagen in it, gives the vessels some resilience. But this is where the smooth muscle resides in arteries, arterioles, and veins. In arterioles, particularly, in arteries and arterioles, the muscular wall is much thicker than it is in veins. And it's particularly thick in the arterioles. And this smooth muscle, like all muscles, is innervated, right? It gets a nerve supply. And the innervation to these smooth muscles is through the autonomic nervous system. You know, we have different parts of our nervous system. We have a central nervous system, which is our brain and spinal cord. We have a peripheral nervous system, which is essentially everything else, the nerves that go out to the body. And the autonomic nervous system is part of that peripheral nervous system, and it controls things that we don't think we normally have control over, like heart rate, digestive function, constriction of your pupils, sweating, things like that. It also controls the action or the contraction of these smooth muscles. So these smooth muscles in the arteriole and arterial walls are innervated by sympathetic nerves, sympathetic nervous system nerves. So an example of how this works is that, you're stressed, right? You have to exam tomorrow or something in class, or you have 30 people coming for Thanksgiving. Ooh. So you're a little nervous about it, and people are coming to your door, and your hands get really cold. So you know when you're nervous, you get dry mouth and sweaty hands and cold hands. So one of the things that happens is that in the skin, the nerves to the blood vessels of the skin are active, so they cause these smooth muscles to contract. And that causes the blood vessel lumen here to get smaller, because these are circular muscles around the lumen, so they contract. They're going to make the blood vessels narrower. So your hands get cold because you have less blood flow to your hands. So you know if your hands are really cold, maybe you need to work on a little stress management, right? Get your nervous system to calm down some. So that's a sign of either you've been out in the cold or throwing snowballs, or your sympathetic nervous system is jacked up a little bit. Okay, so that is the tunica media, which is where the muscle stuff happens in arteries, arterioles, and veins. Then the outer layer is the tunica adventitia, and that's largely collagen and elastin. Okay? There are also some structures that are important that are housed in the tunica adventitia, and those are the vasa vasorum, which are the blood vessels to the blood vessels. And then there are also nervi vasorum, which are the nerves that go to the blood vessels themselves. Okay, so those are all housed, carried in the tunica adventitia. Okay, so we know, I've already told you that arteries are a bit more elastic and they're thicker than the veins are, so they can handle greater pressures that are being put through them. The veins, however, have much thinner wall and are much less elastic. Movement of the blood through the arteries is really kind of pressure driven, right? We have the heart pumping to move blood through our arteries. But that's not really the case so much in the venous system. The venous system is really a much lower pressure system. So how do we get blood to move through our veins? One of the ways is it is certainly driven by a pressure gradient. One end is higher pressure and one end is lower pressure, so that causes movement. But one of the supporting features in the venous system is that many of the veins, particularly the deep veins, are located in muscle compartments, surrounded by muscles. So it's really a muscle pump around the veins that helps to kind of propel the blood back toward the heart. So one of the ways this happens is that there are valves in the veins that are not present in the arteries. So you've all heard of varicose veins, probably, I assume. So we have valves in the veins that prevent backflow of blood in the wrong direction or backward flow, just like the valves in the heart work. And they're really kind of constructed the same way. Connective tissue covered by some endothelium, maybe some elastic tissue. So as we have develop a pressure gradient in our venous system, and additional constriction of the blood vessels by muscle pumping action, the blood is pushed back up toward the heart and moves past a valve, opens the valve to push past it, and then the valves close and prevents the blood from pooling back down. So that's the normal situation. So here's a picture here of normal valves, the blood being pushed up through the vein, opening the valves, and then the valves closing. That's what's supposed to happen. If the valves are weak, either through trauma, injury, excess weight, age, congenital defects in the valves, any number of reasons. If the valves are weak, the blood in the venous system can then drop back down through an open valve or through an incompetent valve and pool in a segment below that. And that causes that segment of the vein to become kind of distended and engorged and overstretched. And that's a varicosity. And sometimes the varicosities can really kind of fold over on one another and become somewhat tortuous, so crooked and bent. And that's what you see in extreme cases where you have the bulging veins and this really loopy appearance of the venous structures in these superficial veins of the leg. So this is a varicose vein. A little more common in women. Could be related to pregnancy, excess weight, and other congenital factors as well. So we've talked so far about really the kind of the micro architecture of the vasculature. So now we want to go back and talk about gross anatomy. So the arteries and veins are named primarily for where they are or where they're going or what their target tissue is. Like the renal veins. The renal veins are going to go to the kidneys. The brachiocephalic trunk. Brachium means arm and cephalic means head. So the brachiocephalic trunk is going to branch into vessels that are going to go to the arm and to the head. So some of these anatomical terms actually make sense. And then the coronary arteries, of course, are going to supply the heart. So we'll talk about these first. So the coronary circulation is the circulation of the blood in the blood vessels of the heart muscle or myocardium. And these, again, are going to deliver oxygen-rich blood to the myocardium, and these vessels are called the coronary arteries, and there's a right and a left. So just here is our aorta, and you remember that the aorta has aortic valves, 3 valves that sit kind of at the base of the aorta. If we were to look inside the aorta and look at the valves, you would see this sort of couple of bowl-shaped structures that we call the aortic sinus. And it's at that level of the aortic sinus that these coronary arteries come off of the aorta. It looks like there's lots of communication between these vessels. When vessels connect, it's called an anastomosis. And in fetal life, there really is an abundant amount of anastomosis between the right and left coronary arteries. But in adults, actually after about the first year of life, that anastomosis is really pretty minimal. So there's not a lot of communication between the right coronary and left coronary arteries. So if we lose one of them, we lose circulation to part of the heart. So it's really critical to have decent coronary circulation. It's really important to heart health. There are examples where there's some collateral circulation that actually will come off of one artery and go into an area that was fed by a subsequently blocked artery. That takes a lot of time. So if the block is relatively fast, you don't have time to develop collateral circulation. So that's something that takes place over a long period of time. All right, so let's talk about the right coronary artery first. So obviously this is going to come off of the right side of the anterior part of the aortic sinus, and it passes anteriorly initially here, and then it passes kind of slightly to the right, and it passes under the auricle. So remember, the auricle is this little thing that looks like an ear. Well, it doesn't really look like an ear, but that's what auricle means, so that's what we'll call it. So this is the auricle of the right atrium. So that right coronary artery can be found sort of coursing right underneath that auricle. And then it reaches the atrioventricular groove, which is the groove that's between the atria and the ventricles on both sides, wraps around the heart. So it reaches this groove, and then it descends to the border on the right side of the heart, which is the right cardiac border here. And it gives off a branch called the right marginal branch, which really supplies quite a bit of the right ventricle. As the right coronary artery wraps around the back of the heart, here, still traveling in the atrioventricular groove, when it gets to the interventricular groove in the back, or the posterior interventricular groove, then it gives off a pretty significant branch called the posterior interventricular branch. Some people call this the posterior descending artery. That's more of a clinical term. Anatomically, it's this posterior interventricular branch. So in addition to supplying blood to the right ventricle and the right atrium, the right coronary artery supplies maybe 30% of the blood to the left ventricle as well. So it's a pretty important artery. In about 85% of us, a coronary circulation is considered right dominant, which means that this artery, this posterior descending artery, comes off of the right coronary artery. So that's the usual case. Most of us, 85% of us, are going to be right dominant with our coronary circulation. This artery, this posterior descending or posterior interventricular branch, supplies the inferior part of the wall between the ventricles, much of the septum, and then the posterior portion of the ventricle. Also importantly, though, is that this right coronary artery gives branches that supply the nodes, the SA node and the AV node in most people. So it has a pretty important function in terms of maintaining blood supply to the conduction system of the heart. All right, then we move over to the left coronary artery, which is bigger in diameter than the right coronary artery, but much, much shorter because it branches earlier. So we don't call it the left coronary artery once it branches. So this and its branches supplies a greater volume of myocardium because it supplies most of the left ventricle, which is much thicker than the rest of the heart. So in terms of the volume of myocardial tissue, the left supplies more. And importantly, it supplies most of the left ventricle. Let's see, it comes out from the aorta again between the pulmonary trunk and the auricle of the left atrium. So that's where you can find it if you were to do a dissection of this. It reaches the AV groove and the atrioventricular groove right between the atrium and the ventricle on that side. And then it branches. And its two big main branches are the circumflex and the anterior interventricular artery. So the circumflex, like its name would suggest, circles around the back of the heart. So here is the circumflex. So left coronary artery here, very short, giving off two big branches. The circumflex branch, which wraps around posteriorly here, and then has branches that extend toward the apex of the heart. And then the anterior interventricular branch here, which it and its branches really travel all the way down pretty much to the apex of the heart. And it's found in this anterior interventricular groove between the two ventricles. The other name for the anterior interventricular branch is the left anterior descending artery. So if we looked at let me go back one. If we looked at this one, we call this the posterior descending. And this one we call the left anterior descending, or the LAD. So clinically, that's what you're going to hear this one called. The LAD typically supplies about 50% of the left ventricle, probably more in most people. And if you figure that 15% of us are going to have left dominant coronary circulation, which means that the posterior descending artery is going to come off of the left coronary artery, then even more of the left ventricle is going to be supplied by the left coronary artery. So if you have a block to the left coronary artery, then you're going to lose quite a bit of function of your left ventricle. So since the left ventricle really provides much of the force to propel blood out of the heart, then death or damage to the left ventricle is significantly problematic. So a block to this artery may result in significant myocardial infarction and death. And you might hear about the widowmaker, a significantly or severely blocked left anterior descending, or LAD, is sometimes called a widowmaker because of its propensity or the risk of death associated with a block to this artery. Another feature of the coronary circulation, in addition to providing the walls of the heart, the walls of the chambers, is that it provides blood supply to the papillary muscles as well. So you remember what the papillary muscles do? They attach to the chordae tendineae, attach to the valves, and prevent backflow of blood into the atria, particularly in this case. So if the blood flow to the papillary muscles is reduced and the papillary muscles are damaged, then you might get mitral valve prolapse and mitral regurgitation in the case of damage to the papillary muscles in the left ventricle. So you could have an MI and mitral regurgitation. So the narrowing of these blood vessels, the coronary arteries, is coronary artery disease or coronary heart disease. And this narrowing is often caused by atherosclerotic plaque buildup, which is lipid deposition in the intima, right, in that inner wall of the vessels. So if that happens, you have a narrowed lumen and decreased blood flow to the structures that are supplied by those vessels. And that is ischemia. So ischemia is reduced blood flow. And ischemia, lack of blood flow to a muscle that's working, is painful. You get buildup of byproducts of muscle contraction. You get inflammation and irritation to the nerves that are carrying pain signals back to the brain. So you can get referred pain from ischemic heart conditions, or you can get localized pain. And the pain from cardiac ischemia is called angina pectoris. So here's an example of somebody that has just come out from a big fatty meal. He's probably stressed, right? He's working, he's got his briefcase, and it looks like he dropped his cigarette there, so he's kind of prime for heart disease. You know, he's got many risk factors for heart disease. So how many of you had a cheeseburger and fries for dinner on your way here? So think about that as your arteries are clogging with a lipid from that food. Because the American Heart Association tells us that more than 17 million people have coronary heart disease, and coronary heart disease is responsible for more than 30% of deaths in adults over the age of 35. So there's your lecture on heart health for the day. So we've talked about the arterial supply to the heart, and now we need to talk about the venous return from the heart, because just like it has its own arteries, it's going to have its own veins as well. So we're going to learn about the big three veins. The big three are the great cardiac vein, the middle cardiac vein, and the small cardiac vein, and they travel with the arteries. So the great cardiac vein can be found in that interventricular groove with the left anterior descending or the anterior interventricular artery. And it drains the same region of the heart that artery supplies. Okay, so that's the great cardiac vein. The middle cardiac vein can be found in the posterior interventricular groove with the posterior interventricular branch, or the posterior descending artery. And then the small cardiac vein can be found with the marginal artery. And then the coronary sinus here drains those veins. It receives the blood from those veins and many others. And then that drains into the right atrium. So the coronary sinus is returning the deoxygenated blood from the heart to the heart into the right atrium with the deoxygenated blood from the systemic circulation as well. Okay. All right. This is Adam Christian Thebesius. And so if you want to be an anatomist, you need to get something named after you. So there are these other veins in the heart called Thebesian veins that actually drain venous blood from the internalmost part of the heart directly into the chambers of the heart. So these are returning deoxygenated blood directly to the heart without going into the coronary sinus or without going into the vena cava. I just love the name Thebesian, though. It's a great term. But there are some things that don't have your names on them yet, so you still have time. All right. So now we've got this deoxygenated blood back in the heart from the coronary sinus and also from the IVC and the SVC, right, the vena cava, into the right atrium. So now we need to get rid of the carbon dioxide that's in that blood and pick up some oxygen. So we need to send that blood to the lungs. So again, right atrium, right ventricle, out through the pulmonary artery, or pulmonary trunk, out to the pulmonary arteries to the lungs. So with ventricular contraction, or what we call systole, the blood is pumped out through the pulmonary trunk, out toward the lungs. Then you can see here pulmonary trunk splitting into two pulmonary arteries, a right and a left, going to its respective lung, right and left lung. And then near the root of the lung, the pulmonary artery on each side is going to split into lobar arteries and then segmental arteries to go to individual segments of each lung. So to understand a bit more about how this gas exchange happens in the lungs and how we exchange our carbon dioxide for oxygen, we should probably discuss a little bit about how air gets down there. So this is not really part of our cardiovascular anatomy lecture, but I wanted to just point a few things out. That when we breathe air in, typically we breathe it in through our nose, through the nasal cavity, nasopharynx, oropharynx, into the larynx, right, your windpipe, and then down into the trachea. And you remember last time we felt this sternal angle right here? Yeah, remember that? That's about where you'll see this trachea bifurcate. So about there, the trachea splits into primary bronchi. And then for each lobe of the lung, then the primary bronchi is going to split into lobar bronchi. And there are 3 lobes in the right lung and 2 lobes in the left lung. So you'll have 3 lobar bronchi on the right and 2 on the left. And then those are going to split even more to go out to the individual bronchopulmonary segments. So you have this branching pattern, more and more and smaller branches, until you get down to the respiratory bronchioles and then the alveoli, which are the little respiratory sacs at the end of the respiratory little bronchioles. Okay? So these are the little air sacs that are also very, very thin, 1 cell layer thin. And that's where gas exchange happens, because each of these alveoli then is sort of surrounded by a capillary bed. Here is our pulmonary artery from the right heart, bringing carbon dioxide now, surrounding the alveoli, forming this capillary bed. Remember, the arteries become arterioles and smaller vessels until they form capillaries. And in this case, this end is bringing carbon dioxide, and it's going to give it up to the alveoli. And the alveoli contain that air we breathed in, which contains oxygen. So the alveoli are going to give up oxygen to the blood supply in the capillary bed, and then that oxygen is going to be carried back by the pulmonary veins to the left side of the heart. So that's where pulmonary gas exchange happens. So this is the intrapulmonary circulation. So that is the case in postnatal pulmonary circulation. But that's not the case in a fetus, though, right? Because a fetus's lungs are not developed, so gas exchange doesn't really happen in the lung in a fetus. So what happens in the fetus? Last time we talked about the fossa ovalis in an adult heart. So I want to talk about kind of where that comes from. So in prenatal circulation, we have deoxygenated blood going into the right atrium, but it doesn't need to go to the heart because the heart's not going to give it any oxygen, right? The lungs are, we need to go to the lungs, but the lungs aren't going to provide any oxygen to that blood. So we're going to bypass the lungs. So we need a way to shunt the blood from the right side of the heart to the left side of the heart without going to the lungs. So there's 2 ways to do that. One is through the foramen ovale. So remember, the foramen ovale is between the right and left atria. And in the right atria, we have deoxygenated blood. So we can move that deoxygenated blood from the right atria just directly to the left atrium through the foramen ovale. So it doesn't have to go to the lungs. But some of that blood may actually get into the right ventricle because there's still, there's an opening there. And then the right ventricle, theoretically, would pump the blood out to the pulmonary artery and then to the lungs. But that's not an open circuit at this point. So there's another shunt between the pulmonary trunk and the aorta called the ductus arteriosus. So we have 2 lung shunts, or 2 circulatory shunts that move the blood away from the lungs, that bypass the lungs. So it's the foramen ovale and the ductus arteriosus. At birth, however, the situation changes. So the lung bypass, the foramen ovale, with the expansion of the lungs at birth and increased blood flow through them, there's increased pressure in the left side of the heart and decreased pressure on the right side of the heart. So that causes that flap between the two atria that covers the foramen ovale, causes that flap to close and eventually seal. So then it becomes the fossa ovalis, which we can see in an adult heart. It's just a little thin part of the septum between the two atria. So that then becomes the fossa ovalis, and it's closed in most people. In about 25% of people, the fossa ovalis stays open. It becomes a patent foramen ovale. The other shunt, this one here, between the pulmonary artery and the aorta, becomes occluded, closes off, and becomes a ligamentum arteriosum. And that it actually can be found in an adult heart as well. So it stays a persistent ligament. It's not patent, though. It's not open, so no blood goes through there. So the fossa ovalis and the ligamentum arteriosum are the adult sort of remnants of this fetal circulation that's designed to bypass the lungs. So you can have a patent foramen ovale in an adult. And that happens in about 25% of the population. It's usually asymptomatic, though. In most people, it's asymptomatic. It's only symptomatic if there are other cardiovascular defects. There are other atrial septal defects that are problematic, but this one's not. It's fairly small. There is some evidence, though, that in people that have what's called cryptogenic stroke, which is a stroke that they can't really relate to any particular problem, that more people with a cryptogenic stroke have patent foramen ovales than people that don't have this type of a stroke. So there may be some implication that in this particular kind of stroke, which is a cerebrovascular accident, where you get a block in an artery to the brain. So the thought is that if somebody has a blood clot, for example, in the venous system in the legs, and that clot gets returned to the right atrium, small clot in the right atrium, then if this person has a patent foramen ovale and they do something that increases the pressure in that system, like a Valsalva maneuver or cough or straining in some way, that increased pressure may shunt a little bit of the blood from the right heart to the left heart through that patent foramen ovale and bring the clot with it. Very small little clot moving through this small defect. And then once it's in the left atrium, then you'll see in future slides that that can be pumped through the left ventricle and then out into the systemic circulation, which includes the carotid artery to the brain, so that then you can get this stroke related to this defect in that way. Not common, but it does happen. Okay, so back to the adult systemic circulation now. So we've gotten our oxygen-rich blood back from the lungs, right? So we've sent it to the alveoli to pick up some oxygen, and now it's going to be come back to the left heart, and then we're going to be ready to send it out to our body. So remember that blood from the left ventricle exits through the aortic valve to the aorta, and then out to the systemic circulation. And remember that we have arterial branches branching to smaller arteries, to arterioles, then to capillaries, and then the nutrients coming out to the cells and tissues. So let's talk about some specifics, some more gross anatomy. Where are these vessels? Where do they come from? Where do they go? So the branches off of the aorta that we know about already are the coronary arteries, right? So they come off very early. The aorta is, you can consider it in sort of regional parts. The first part of the aorta is the ascending aorta. That's the part that comes off the heart. This portion of the aorta right here is the arch of the aorta. So here again, this is our tracheal bifurcation. Remember, that's at that sternal angle. So this tells you the beginning of the aortic arch is here and the end of the aortic arch is there. So the aortic arch starts and ends at about that same level, at that sternal angle, just to give you some anatomical reference. And here it is in situ here. So here's the aortic arch right here. So from the arch of the aorta are three big branches. The first one here, this is the first branch, is the brachiocephalic trunk. So as its name implies, it's going to provide oxygen to the arm and to the head. So brachium meaning arm and cephalic meaning head. The next branch is the left common carotid here. So that's going to go up the left side of the neck toward the head. And then the third branch is the left subclavian. So it travels under the clavicle, right? So it's subclavian. Okay. So these three vessels provide really all of the circulation to the head and the arm, the neck, shoulder girdles. So we're going to kind of follow this along, starting with the carotid artery. The carotid artery here ascends bilaterally, right? There's a carotid artery on either side. On the left side, we see the common carotid coming off of the aortic arch. But where is it on the right side? And we know where it comes on the left side, but where does it come off from the right side? So it has to come off the brachiocephalic trunk. The brachiocephalic trunk in the superior part of the mediastinum, as it's exiting the thorax, is going to divide into the right subclavian and the right common carotid. So now we can follow these carotid arteries up into the neck and up into the head. So just to orient you to some other structures, here's your thyroid gland. This cartilage right here is your laryngeal prominence or your Adam's apple. Can you guys feel that? Everybody know where their Adam's apple is? Yeah? Okay, so that's your laryngeal prominence. And if you follow your laryngeal prominence laterally, then you'll run into your carotid artery and you can feel your carotid pulse there. Okay? Just superior to that, or just toward the head of that, the carotid artery splits into two arteries, an internal and an external carotid artery. The internal carotid artery is going to go to your brain, and your external carotid artery has many branches off of it that supply the neck, the face, the external surface of the head. There's a little place, right? You guys watch Star Trek? You ever see Spock do the Vulcan nerve pinch thing? Yeah. So one of the theories about that, okay, I know it's fiction, I get it, but one of the theories, there's a couple of structures that are sort of located at the bifurcation of the carotid artery. One is the carotid sinus, which is it's a baroreceptor. It responds to pressure changes. And the other is the carotid body, which is this little reddish-brown glob that sits in the crotch, right in that bifurcation. And it responds, it's chemoreceptor, so it's going to respond to oxygen levels and pH. So if there's changes in oxygen and pH, if you become hypoxic or your pH drops, then the chemoreceptor, the carotid body, will stimulate a reflex to sort of increase your respiratory rate. The carotid sinus is the pressure receptor. So one of the theories about why the Vulcan nerve pinch, whatever it's called, works is that their external pressure on that carotid sinus causes the body perceives this external pressure, so it drops your blood pressure to compensate, and then you have a syncopal event, which is fainting. So, yeah, I know it's pretend, but that's how they tried to explain why it worked. So it's based on this anatomical feature in the neck, this carotid body, or carotid sinus. So those are found here. You can there are cases where people have massaged their carotid sinus and caused a syncopal event, but that usually only happens in people that have carotid sinus hypersensitivity. It's sort of a congenital condition. Okay, so that is your carotid artery in your neck, and again, there's two of them, right? And you can palpate that pulse in your neck. So if you're going to palpate one side at a time so that you don't cut your blood flow off to your head. And don't massage your carotid sinus, please. All right, so now we're going to come back to the kind of the root of the neck. So you'll remember this right here is the brachiocephalic trunk. So this is going to be the right side. We're looking at the right side of the body. And here is the right common carotid, and it's splitting into an internal and an external carotid. And then we have the subclavian artery. So now we're going to look at the subclavian artery in a little bit more detail and look at its 3 branches. It's got 3 important branches off of it. One is the thyrocervical trunk, and it supplies the thyroid gland and structures in the neck. Another is the internal thoracic artery, also called the internal mammary artery, and it travels inside the thorax, kind of hugging the thoracic cage, but on the inside. And it's an important artery for a number of reasons, but clinically, it's often used in coronary artery bypass grafts. So this artery can be taken, cut away, and used as a graft to bypass coronary artery blockage. So a coronary artery bypass graft or CABG is a surgery in which a patent or open blood vessel in good health is used to you sew it onto the heart and bypass the blocked coronary circulation. So this is used more commonly now than in the past. It used to be the great saphenous vein from the leg, which I'll show you or talk about a little bit. But this one apparently has better outcomes, stays open a bit longer. It's a little bit more resistant to failure and to atherosclerotic plaque buildup, apparently. Okay, so the third vessel that's important off of the subclavian artery is the vertebral artery. So it's called vertebral because it actually travels up the cervical spine in little holes on the vertebral bones themselves. So it's sort of protected by the vertebra, but it also supplies the brain. So here's your brain. Here's the base of your brain. So if this were my brain, it would be down like this and sitting in my head. So we're looking at the undersurface of a brain. So what you'll see here, these little dots right here, these holes, those are the internal carotid arteries coming from you guys toward the brain, okay? And then here are the vertebral arteries coming from those vertebral arteries in the neck, and they join to form the basilar artery at the base of the brain, and then the branches off of the internal carotid and branches off of the basilar actually do anastomose, and they form a circle, a continuous circle of arterial blood called the circle of Willis. So theoretically, if one of these is blocked, so maybe you have a problem with the basilar artery, reduced blood flow, then you might be able to make that up with the internal carotid blood flow. So there's some redundancy to the blood flow in the brain. That's a good thing. But you can see how if you have a block to a vertebral artery or a block to a carotid artery, how that could limit blood flow to the brain. Another thing that you can see is that if you have a blood clot coming from some other structure, from the heart, from the left side of the heart that travels up the carotid artery into the internal carotid artery, it can actually find its way to a smaller vessel and get lodged, and then really restrict the blood flow to part of the brain, and that's a stroke. That's an ischemic stroke. So you lose blood flow and oxygen to part of the brain because there's a blockage in one of these smaller vessels. And it usually happens where a branch comes off, where there's a change in direction, because there's a marked reduction in size of the vessel there. Okay, so back to our subclavian artery here. Goes underneath the clavicle, and at the edge of the first rib, the subclavian artery changes its name to axillary. So now I know that this area is, you know it as your armpit, but now that you're an anatomist, it's called your axilla. Okay, so we call this the axillary artery. So the axillary artery and its branches really provide the circulation down the arm. So at kind of the margin or the lateral border of your axilla, the axillary artery becomes the brachial artery. And then its branches really supply the rest of the arm. There's a deep brachial artery that kind of courses around the back of the humerus. Then at the front of the elbow, at the antecubital fossa here, the brachial artery splits into some arteries that you know, the radial artery for one, and then the ulnar artery. So you can find some pulses in the upper extremity as well. You can feel your brachial pulse on the inside of your arm, and you can feel your radial pulse easily at your wrist. So those are some important pulse points. So now we're going to follow the aorta down into the thorax. So here's our arch of our aorta again here, and then the descending or the thoracic aorta. And you can see many branches off of this. There are paired branches that supply the intercostal area. Those are the posterior intercostal arteries. And you can see them between the ribs. There are esophageal arteries that go to the esophagus. There are bronchial arteries. So we know we have the pulmonary arteries that go to the lungs to pick up oxygen. But we also have bronchial arteries that go to the lungs to actually bring oxygen-rich blood to the lung tissue itself, because the lung has tissue that needs to be supported. So that's provided by the bronchial arteries. So now you can follow the thoracic aorta down through the diaphragm here. So this is the diaphragm. It separates the thoracic cage from the abdominal cage. So the thoracic aorta goes into the abdominal cavity just behind the diaphragm. And then it does a bunch of stuff in the abdominal cavity, because it needs to supply really all of the structures of the gut, all of the abdominal structures, and then it needs to also supply the pelvic structures as well. So in the abdomen, we have unpaired arteries off of the aorta and paired arteries off of the aorta. So the unpaired, meaning there's only one of them, there are 3 primary unpaired arteries off the abdominal aorta. The celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery, and those supply the structures related to digestion. So stomach, liver, pancreas, small and large intestine. Then we have the paired arteries off of the abdominal aorta, and you can see these here. There's the renal arteries. Of course, those are going to go to kidneys. There's 2 kidneys, so there's a right and a left renal artery. There are lumbar arteries. There are also gonadal arteries, testicular and ovarian arteries, and those are paired because we have 2 of those too. And then what you'll notice is at the end of the aorta, about if you put your hands on your hips, you're on top of your iliac crest. And that's about the level of maybe L4, L5 vertebral body. And it's at about that level where the aorta splits into 2. It splits into a right and a left common iliac artery. And then the common iliac artery splits into an internal and an external iliac artery. And the internal iliac artery supplies most of the structures in the pelvis, some in the gluteal region. And the external iliac artery continues down, passes underneath the inguinal ligament between your abdomen and your thigh, and becomes the femoral artery. So the femoral artery is really the primary blood supply to your lower extremity. And here it is again, so you can see the external iliac artery becoming the femoral artery. There's some significant major branches off the femoral artery that supply really most of the muscles in the thigh. There's another little artery medially called the obturator that we don't pay much attention to. The femoral artery is really the big one. As the femoral artery descends in the thigh, it sort of migrates posteriorly toward the back, and it ends up behind the knee. And now it's called the popliteal artery. So that is that femoral artery can be palpated for a pulse in the femoral triangle up in your groin, and then you can also palpate the popliteal pulse in the popliteal space behind the knee. So there's some really key palpation points here, and the reason that I talk about pulse points is because you can really assess the integrity of the circulatory system by palpating pulses, which we'll talk about. As the popliteal artery descends past the knee into the leg, it branches into an anterior and a posterior tibial artery to supply the leg and the foot. And you can also feel those pulses as well. So the posterior tibial artery travels in the posterior part of your legs, underneath or deep to your gastrocnemius, your big calf muscles, sort of deep in that posterior compartment. And then its pulse can be palpated just behind the medial malleolus. Okay, what's that? Anybody know what the medial malleolus is?
It's a process on the...
So your ankle bones, now that you're anatomists, are called malleoli. Yeah, so the inside ankle bone, the one closer to midline, is medial malleolus, and it's the distal end of the tibia, or the end at the bottom of the tibia. And your lateral malleolus is the distal or lower end of the fibula. So those ankle bones are really part of your leg bones. And you can palpate the posterior tibial pulse just behind or just posterior to the medial malleolus. The other pulse that you can feel in your leg and your foot is the dorsalis pedis pulse or dorsalis pedis artery, and it's the continuation of the anterior tibial artery. And that one you can feel on the top of your foot. So these are commonly palpated when you go to the doctor or you're in the hospital and they're checking your peripheral pulses. These are the two that are most commonly palpated to check for patency of those vessels down at the end, supplying blood to your distal extremities. So why do we palpate pulses? What do we monitor when we do this? So there's certainly when you check your pulse, you're checking for the rate, right? You check your heart rate by palpating your pulse. In an adult, the pulse can really range from 50 to 100. The normal pacing of the pacemaker, the SA node, is like 60 to 70, but our heart rate is somewhat variable depending on any number of factors: exercise, stress, general health. If your resting heart rate is over 85, it may be a sign of deconditioning. So, your resting heart rate just sitting here should not really be over 85 typically. A condition called bradycardia is a heart rate that's less than 60, or tachycardia is a heart rate that's over 100. You can also check the rhythm of the heart rate. So most of us are going to have a regular heart rate, right? It just does this, right? Very regular. But not everybody in here has a regular heart rate. You may have an irregular heart rate, and it might be regularly irregular, right? It could be like this, right? That's irregular, but it's regular. Then you could have an irregular heart rate. So that would just be random, right? It'd be, that's what my husband sounds like, and it's worrisome to me. Sometimes I think, it's not going to start again. He's done, it's not beating anymore. So that's one of the reasons to check pulse, right? You count rate and you assess the rhythm. Another reason to check pulses, though, is to check the patency or the openness of the vessels, right? So if the vessel is completely occluded, you're not going to feel a pulse distal to the site of occlusion or blockage, right? So you can, if I'm complaining of pain when I walk in my calf muscle on my right side, it just cramps. Every time I try to walk, it cramps up terribly. And my right foot is cold, and I don't have any hair growth on my toes on my right side. So we might feel a pulse in my femoral artery, and we might feel a pulse in my popliteal artery, but maybe I don't feel a pulse in my dorsalis pedis or my posterior tibial artery. So somewhere between my popliteal artery and those other distal or more distant arteries, there's a block somewhere, and it's causing pain when I try to use my muscle. It's causing ischemic pain. So you can palpate for the patency of the pulse, right? So 0 is absent, no pulse at all. You can have a weak or a really thready pulse that's just not very strong. 2+ is normal. You can also have a bounding pulse. That you might feel a bounding pulse after you've sprinted across the street, or you might have a bounding pulse if you have congestive heart failure. So it's not always a good thing. So there are some other signs, in addition to having an absent pulse, there are some other signs of loss of patency of the vessels, of the arteries. So diminished amplitude of the pulses we talked about, hair loss. So it takes a lot of blood supply to get hair to grow on your big toe. I bet everybody in here has hair on their big toe. I want you to go home and check, see if you have hair on your big toe. And don't worry if you don't. But if there are other signs that point to loss of blood flow, then hair loss in the distal extremities may be another sign. Cool skin temperatures, maybe decreased circulation as a result of that, cyanosis or blue skin or dry skin, and then intermittent claudication pain with activity, which is what I described it with my calf pain. You can also monitor your pulse or your heart rate at the apical pulse. And that's, you remember where the apex of the heart is? You have that mid-clavicular line, and you have the fifth intercostal space, and that intersection is kind of where the apex of the heart is. So you can listen with a stethoscope for the apical pulse. And you're not really listening to that, you're not, feeling the wave of blood that you would palpate in a pulse in the periphery. You're actually listening for a sound. And the sound that you hear is that lub-dub sound. And that sound is the sound of the valves closing. So the first lub that you hear when you auscultate at the heart is the closure of the atrioventricular valves, which are the tri- and the bicuspid valves. And then the dub, lub-dub, is the closure of the semilunar valves, which are the aortic and pulmonic valves. So doing those assessments can really give you some ideas about the health of the heart, the cardiovascular system. So we've talked about the arterial flow out to the systemic circulation, and we just want to really briefly touch on the venous return. So you all know about your internal jugular vein, you know where that is, and your neck. Again, those are bilateral structures, meaning both sides, draining the brain. There are external and anterior jugular veins that also drain the head and neck structures. And those are going to drain, they're going to join up with the subclavian veins and form brachiocephalic trunks that join together to form the superior vena cava. So these are draining the head and the neck into the superior vena cava. Venous drainage from the thoracic cavity really essentially follows the arterial supply. So there are intercostal veins and esophageal veins. There are bronchial veins, and those drain into the azygous system of veins that then drain into the superior vena cava. So again, this is just bringing deoxygenated blood from the structures in the thoracic cavity and from the thoracic wall. Venous drainage from the gastrointestinal system, though, is a little bit different. So we talked about the 3 unpaired branches off the aorta that go to the gut structures. The venous drainage from the gastrointestinal system goes through the liver before it gets into the caval system, before it goes into the inferior vena cava. Because the liver does a lot of detoxification, right? So what you've taken in and ingested needs to be processed by the liver before it gets put back in your systemic venous return into the inferior vena cava. So all of these veins, the inferior mesenteric and the superior mesenteric and splenic vein, draining the foregut, midgut, and hindgut, are going to end up in the hepatic portal vein, go through the liver, get processed, and then go into the inferior vena cava. And then venous drainage from the lower extremity is just going to essentially follow the arterial supply. The veins travel with the arteries, draining the same regions, and end up in the femoral vein. There's some superficial drainage from the skin and superficial structures that is carried by the great saphenous vein that drains into the femoral vein. And that's the vein that is sometimes used for a coronary artery bypass graft. We can live without that vein. Not done as commonly as it used to be. You may have seen people with big scar down their leg after a coronary artery bypass graft. That was because they took the saphenous vein and used it for the graft, for the donor. So the venous return from the lower extremities is essentially through the femoral veins, follows external iliac, common iliacs, inferior vena cava, right heart. You can imagine that if you had a blood clot in the deep veins in the leg, how that would get up to the heart. So it would just follow the venous return through the femoral vein, find its way to the inferior vena cava, and then end up in the right side of the heart. So then the venous return from the upper extremities, we have the axillary vein, we have a subclavian vein. The subclavian veins draining the upper limbs joins with the internal jugular vein draining the head and neck to form the brachiocephalic veins, and then the brachiocephalic veins come together to form the superior vena cava. So that is the venous return from the upper body, head, neck, and arms. So I wanted to touch just briefly again on the conduction system of the heart, because we talked about the pulse. We talked about assessing your pulse to assess your heart rate. And your heart rate is a reflection of the conduction system essentially in the heart, kind of dictated by the SA node. So the sinoatrial node is the pacemaker of the heart. Those are those specialized cells that beat on their own. And the region of the SA node happens to be a region that has sort of the fastest pacing, so it wins, so it gets to determine the heart rate. So this sets the rate of contraction for the rest of the heart. So the impulses from the SA node are conducted through the atria to the AV node, or the atrioventricular node, and that is in that interatrial septum. From there, the impulses are conducted through the bundle of His, and that crosses that fibrous skeleton, which actually is an impediment to just the atrium just contracting impulses down to the ventricle. So that fibrous skeleton slows things down, and the only conduction can happen across the fibrous skeleton at the bundle of His. And then the bundle of His branches to the right and left bundles, and then to the Purkinje fibers, and the Purkinje fibers are going to conduct the impulses out into the ventricles. So if the SA node has its sort of own pacing, then how does heart rate ever change? If we have this sort of intrinsic pacing system at the SA node. So the heart is innervated extrinsically as well, again by the autonomic nervous system. The autonomic nervous system has two parts to it. It has a parasympathetic and a sympathetic nervous system. So the sympathetic nervous system is that fight or flight response, right? That, you cross the street and the bus is gunning for you. You need your sympathetic nervous system to kick in so that your heart rate goes up, so your pupils get big so you can see, right? So your hands will sweat and the blood is shunted toward your big muscles so you can run. So that's your sympathetic nervous system, that's fight or flight. So your heart rate is going to go up with sympathetic system stimulation. The other part of this autonomic nervous system is the parasympathetic nervous system, and that is going to slow your heart rate down. That's called the rest and digest system. So that's really a recuperative sort of resting condition. So if you take your heart rate, see if you guys can try this, just for a few seconds. Take your heart rate at your wrist. Find your radial pulse and take it with your fingers, not your thumb, because there's a bit of a pulse in your thumb and it may be a little hard to count. So find your pulse. Everybody found it? Now I want you to just take very slow, deep breaths for just maybe 15 seconds and just feel your heartbeat. And what I want you to see is if when you breathe in and out, if you can feel a change in your heart rate. When you breathe in, does it beat a little bit faster? When you breathe out, does it beat a little bit slower? Can you be sensitive enough to feel that? So you can practice that. That's called heart rate variability. And that's a normal physiological mechanism that when you breathe in, your heart beats just a little bit slower, and when you breathe a little bit faster, and when you breathe out, it beats a little slower. And that is kind of a reflection of the health and balance of the autonomic nervous system. So people that are very stressed and have sort of shift toward sympathetic nervous system dominance, they have really much less heart rate variability. So you can use this assessment of heart rate variability as a reflection of your balance between your autonomic nervous system, the parasympathetic and the sympathetic nervous system. You also then could surmise that if you were constantly stressed out and your sympathetic nervous system were aroused, that your heart would beat faster and it would beat harder and your peripheral resistance may go up. So those things are hard on your heart. So there is plenty of evidence that supports that stress has a negative impact on cardiovascular health. So that's my other plug, besides not eating cheeseburgers, is to work on relaxing, work on trying to get your parasympathetic nervous system to kick in a little bit more. All right, so we'll finish up a little bit with the lymphatic system, because I love the lymphatic system. Normal functioning of the cardiovascular system is essential for optimal health and function of our cells and our tissues. But normal function of the lymphatic system is also very important. It has some very distinct functions. It has immune functions, because our lymph nodes are sites of our lymphocytes and macrophages that help to filter foreign products from our circulatory system, or from our lymphatic system. But it's also part of the circulatory system. I'm going to pull up another picture. So this is similar to that other capillary picture where we saw arterioles bringing oxygenated blood to the tissues and depositing plasma and oxygen into the interstitial space. Then the venous system is picking up most of that. So the venous system is going to pick up things that will fit into the venous system: carbon dioxide, other smaller proteins, nutrients, and most of the interstitial fluid. So 90% of the plasma that seeps out of the arterioles or the arterial end of the capillary into the tissue space, most of that gets picked up again by the venous system, 90% of it. 10% of it stays behind in the interstitial fluid, partly because there's proteins in it and it has to stay there, but that has to be picked up by something, and it gets picked up by the lymphatic system. So there are little lymphatic capillaries here that are intertwined with the capillary beds that absorb or pick up that extra interstitial fluid. Those lymphatic capillaries, just like other capillaries, form larger lymphatic vessels and transport the lymphatic fluid up toward nodes where it's filtered, and then toward the lymphatic duct, and then toward the venous system. And that filtered lymphatic fluid gets dumped into the venous system again after it's been filtered by several layers of lymph nodes. So it's really critical that you have an intact lymphatic system to absorb that extra interstitial fluid. Because if you didn't, it would accumulate and it would throw off your protein, osmotic, oncotic sort of balances in your system. So there are conditions in which the lymphatic system is either underdeveloped, there can be congenital problems with the lymphatic system, or it can be damaged. And for example, in the work that I do, I see women post-breast cancer treatment who've had axillary lymph node dissection or radiation that has damaged the lymphatic vessels or the nodes. So in this region, for example, here, if these lymph nodes are gone or the lymphatic channels are damaged, then that lymphatic fluid that's building up in the arm doesn't have anywhere to go. It may get absorbed to a certain extent by the existing lymphatic capillaries, but it doesn't have anywhere to go, so it sort of runs out of room. So then a condition called lymphedema develops, where you have this excess interstitial fluid that can't be absorbed by the lymphatic system, and it creates a really large lymphadematous arm, that is painful, restricts motion, is a site for infection, because you have the static fluid in the tissue, and it's kind of a breeding ground for microorganisms. So the lymphatic system is actually very important in terms of maintaining circulation in the body, as well as having some immune function in addition. So it doesn't get a lot of press, so I just wanted to give it a plug. And I think that that's it. We've covered only 4 things. We talked about the vessels. We talked about the circulatory systems. We talked about fetal to adult, sort of fetal to postnatal changes in the heart and shunts. And then we talked a little bit about nervous system and lymphatic system as well.